Assalamualaikum warahmatullahi wabarakatuh. Let me introduce myself. My name is Tegar Adil Basri, NPM H1A021008, medical student of Bengkulu University. My lecturer, Ma'am Dr. Wisma Yunita, MPD. In presentation titled Tinea Corporis and Update Review. I will discuss first introduction, second material and method, third result, fourth discussion, and the last conclusion. First introduction. Tinea corporis, also known as ringworm, is a superphysical dermatophyte infection of the skin, other than on the hand, feet, scalp, wear areas, face, groin, and nails. Tinea corporis is most commonly caused by dermatophytes belonging to of the three general, namely Trichophyton, which cause infection on skin, hair, and nail. Microsporum, which cause infection on skin and hair. And Epidermophyton, which cause infection on skin and nails. Dermatophytes are grouped as either anthropoid, zoophilic, or geophilic, depending on whether their primary source is human, animal, and soil. Because tinea corporis is common and many other annulation can mimic this fungal infection. Physicians must familiarize themselves with its etiology and its treatment. Next, material method. PubMed search was performed with clinical queries using the K-term, tinea corporis. The search strategy includes clinical trials, meta-analysis, randomized controlled trials, observation studies, and review. Next, result. Tinea corporis typical present as a well-demarcated, sharply circumscribed, oval or circumnular, midly erythematous, scaly patch, and plangu with raised leading edge. Male preterus is common. The diagnosis is often clinical but can be difficult with prior use of medication, such as calcineurin inhibitors or corticosteroids. Dermoscopy is useful and non-invasive diagnostic tool. If necessary, the diagnosis can be confirmed by microscopic examination of potassium hydroxide with mount preparation of skin scraping from the active border of the lesion. Fungal culture is gold standard to diagnose dermatophysis, especially if the diagnosis is in doubt and result of other tests are inclusive or the infection is widespread, severe, or resistant to treatment. The standard treatment of tinea corporis is with topical antifungal. Systemic antifungal treatment in indication if the lesion is multiple, expensive, deep, recurrent, chronic, or responsive to topical antifungal treatment, or if the patient is immunodeficient. Next, there are three that I will discuss in the presentation. First, diagnose, second, differential diagnose, and the last, complication. The first, diagnose. The diagnosis of tinea corporis is most often clinical, especially if the lesion is typical. A well-dermated, sharply circumscribed, erythematous, annular, scarly plaque with a razor leading edge, and scaling and central clearing on the body is characteristic. At times, the diagnosis can be difficult due to the prior use of medication, such as calcineurin inhibitor or corticosteroid. Dermoscopy is useful and non-invasive diagnostic tool. If necessary, the diagnosis can be confirmed by microscopic examination of potassium hydroxide. wet mouth, preparation of skin scraping from the active border of the lesion. Next, differential diagnosis. Disease that present with annular lesion may mimic tinea corporis. The differential diagnosis is broad and include pityriasis rosea. Complication. Yeah, tinea corporis is contagious and therefore may have significant psychological, social, and occupational health effects. Secondary bacteria superinfection may occur as a result of stretching and abrasion of the skin, or discriminate eczema is a secondary dermatitic eruption that may occur is association with fungal infection, especially just after commencement of systematic antifungal treatment. Affected patients often develop with the spread. The dermatitic eruption is an immunological reaction to the fungal antigen like a delayed type. Fever-sensitive response by tinea corporis have been described. Next, treatment. Treatment is divided into two. The first, non-pharmacological measures. As fungi, treatment based in moist and warm environments, patients should be advised to wear light and loose-fitting clothing. The skin should be kept clean and dry. And second, pharmacotherapy. The standard treatment of tinea corporis is with topical antifungal. The superiority of topical antifungal over the use of placebo, localis or superficial tinea corporis usually respond to topical antifungal therapy applied to the lesion at the least 2 cm beyond the lesion once or twice daily from 2 to 4 weeks. Next, conclusion. The diagnosis of tinea corporis is usually clinical and solved pose no problem to physician provided the lesion is type. However, many clinical variants of tinea corporis exist, rendering the diagnosis difficult, especially with prior use of medication, such as calcineurin inhibitor or corticosteroid. As such, physician must be familiar with this condition so that an accurate diagnosis can be made and appropriate treatment initiated. Next, tinea corporis characteristic conclusion. Well dermatod, serpully circumscribed, midly erythematous, annular, curly plaque with a raised landing edge, and scaling and central clearing on the body characteristic of tinea corporis. At times, the diagnosis can be difficult due to the prior use of medication, such as calcineurin inhibitor or corticosteroid. Furthermore, diseases that present with annulation may mimic tinea corporis. Tinea corporis is common fungal infection and the differential diagnosis is broad and at times difficult. Physician must be familiar with this condition so that an accurate diagnosis can be made and appropriate treatment initiated. Okay? Thank you for your nice attention. And the last I say, wassalamualaikum warahmatullahi wabarakatuh.